I'd like to discuss the surgical repair of epigastric hernias, including umbilical hernias, and potential closure of a diastasis rectus. So an epigastric hernia is a hernia that's above the belly button or umbilicus, and it's in the midline. The muscles of the rectus muscle come together in the midline and are held together by a tendon. If you look at a picture of someone with a six-pack ab, you can see a line down the center and lines across. The epigastric hernia is always in the midline. It's always above the umbilicus or belly button. Sometimes it's fairly close to it. Other times it can be an inch or 2 inches away. Often it is associated with a diastasis rectus. Now what that is there's muscle separation in the abdomen. This can occur because of significant weight gain, or happens to a woman after pregnancy, where the muscles in the midline actually separate, and they can separate an inch, 2 inches, or even more, so that when a patient does a sit-up, you actually will see a bird's beaking, like a mountain, in the upper abdomen, usually above the belly button, and that is a diastasis rectus. Sometimes that can extend below the umbilicus or belly button also. These cause the belly button hernia or the umbilical hernia and the diastasis to get larger over time because their defects are not supported by the surrounding tissues. Question is, how do you fix them? If patient has a diastasis and you only fix the defects with sutures without significant reinforcement, usually by the use of some synthetic material, there's a good chance the patient's hernias are going to come back, whether it be umbilical or epigastric. Very often, if a patient doesn't want to have the diastasis closed, and that is a significantly larger operation if it's extensive, then the way to fix these defects are to do them laparoscopically. You close them percutaneously, which means you lose little teeny incisions the size of a needle, put the sutures in and close the hole, and then you reinforce or buttress the defects with a piece of synthetic material. That will work very, very nicely in preventing an epigastric or umbilical hernia from returning. The mesh needs to go a couple of inches on either side of the defect in order for it to fuse and prevent there to be any recurrences. That is without doing a diastasis repair. You can percutaneously close a diastasis with these external sutures that you don't see because they really just go through the skin and they're under the skin, if the diastasis is not too far apart. But if it's very far apart, that will not necessarily successfully work, in which case you want to, if that is an issue to the patient, you want to close it by doing what we call a component separation, which can either be done open, laparoscopically or robotically, and it is a much bigger surgical procedure and intervention, and should only be reserved for patients who want to have that cosmetic effect. If a patient just cares about the complications, potential issues with an umbilical or epigastric hernia, and they don't care about the diastasis, then simple percutaneous closure with mesh reinforcement laparoscopically certainly is the safest way to go.